Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today, just plain rules. Rule number 189. Use the enema for diagnosis. So, abdominal pain is probably one of the most common chief complaints we see in the pediatric emergency department, basically on a daily basis, sometimes many times a day, and sometimes the abdominal pain has some red flags to it. And one of the red flags that makes me personally a little worried is pain that is intermittent within an hour or two, comes and goes. That always makes me think about intussusception. Having said that, however, interception is very common in very specific age range. Yes, it can happen in adults, it can happen in any age, but it's almost always a 7, 8, 9, 10 months old or just a toddler, hence the rule of 6, which you can find in one of our early episodes. So sometimes when the patient maybe has history of constipation, story that is somewhat compelling for constipation, but he or she also have this intermittent pain that makes me a little worried, I often give an enema in the ER just for diagnosis. So in my mind, if you give a patient enema and he or she are better, completely resolved after having a bowel movement, it's almost definitely constipation. Not that I have anything against doing ultrasound for interception, but if my pretest probability is so low because of that patient's age and no other symptoms that fit, I often do an enema in the pediatric emergency department just to rule out, so to speak, the diagnosis of interception and rule in possible constipation. Again, as always, it's not the patient's job to prove that they're sick, it's your job to prove that they're not. If the patient had an enema, had a bowel movement, and is now better, I would consider that proving that he or she are not sick. So remember, use the enema for treatment, but use it also for diagnosis. Rule number 190. Make a decision and move on. So in the pediatric emergency department, we're often faced with some difficult situations. And under those situations, sometimes it's just difficult to make a decision. Sometimes we know that our decisions are going to have significant ramifications to the patient, and we tend to dwell on it and maybe delay making a decision that sometimes can be counterproductive. Even worse than that, sometimes I tend to make decisions late and then regretting not making them earlier. A good example for that is something that we do fairly often in the pediatric emergency department is intubating a child. I can't tell you how many times when I delayed the decision to intubate a child, I just regretted not intubating him or her earlier. Being hesitant to make such a decision often works against you. Most of us have enough experience in the field of pediatric emergency medicine, and we think we need to intubate a child, it's probably a good idea to just do it. Dwelling and contemplating that decision oftentimes doesn't really help. Furthermore, if you intubated a child, so to speak, unnecessarily, all that will happen in the next day or two is that the patient will be extubated and maybe even sooner. But that is always better than delaying the decision and possibly have some bad outcome for the patient. Another good example for that is a decision that is a little easier to make, but giving or not giving IM epinephrine for anaphylaxis. Sometimes when the child comes in with what looks like or possibly could be anaphylaxis, however, it's not clear cut, I think we all have a very low threshold to give the Benadryl, to give the steroids, but sometimes hesitant to give the IM epinephrine. And dwelling on that decision doesn't help the patient. IM epinephrine is very benign, and if the patient got it unnecessarily, nothing bad happens. Good example of not dwelling on such a decision. Just make a decision based on your experience. If you made a decision, don't dwell on it, execute it, and stand by what you did. Another decision I've often delayed in the past and regretted is not calling the consultants early. I think many of us, myself included, see some weakness in calling the consultants early before you did your whole workup and initiated it. We perceived as people who don't know what we're doing or have very low threshold to get an advice. And sometimes, every once in a while, I actually regret not calling the consultants early. For example, if I did some workup and omitted some important testing, when I often call the consultant, at some point I regret not initiating that testing earlier. And probably one of the decisions that I regret not executing earlier is working up somebody for surgical abdomen. So, many times, especially on busy shifts, it's a little bit of a difficult decision to start going down the rabbit hole of looking for appendicitis with labs and ultrasound. And I cannot tell you how many times I made the decision after the patient was already in the emergency department for an hour or two and I was doing a PO challenge or trying to delay making a decision. I often regret it. So if you think you have surgical abdomen, make a decision, stand by your decision, and work up the patient. If you think the patient needs to be intubated, make that decision, make it early, don't dwell on it, and move on. For the most part, nothing bad will happen if the child needs to be extubated shortly after. Rule number 191. Don't intubate and leave. So this is something I think I learned from our ICU colleagues. There is more to intubating a child than just putting the tube down their throat. After I intubate a child, I always consult with the respiratory therapist or maybe the intensivist in the room. How should we ventilate the patient? There are many modes, there are many things to consider, and I think most of us, pediatric emergency department or even emergency department physicians, are not necessarily comfortable with that management. We often rely on our respiratory therapist or our ICU colleagues to manage the patient on the vent. We all know how to intubate very easily, but don't necessarily do a whole lot from there. So my advice, don't intubate and leave. Sit with the respiratory therapist and discuss how you're going to ventilate the patient, learn about it, but don't be the person who tubes the patient and leaves the room. There are many things to consider. Why didn't you intubate the patient? How is the patient being vented manually? Is it easy? Is it not? What is the lung process? What is the physiological process you intubate the child for? So again, don't put the tube down their throat, look like a hero, and leave. The management of an intubated patient does not end after intubation. And that is it for today, guys. Thank you very much for listening to PEM Rules. Let's review what we learned. Rule number 189. Use the enema for diagnosis. If you think you're dealing with a child who has abdominal pain secondary to constipation, yes, enema can be the treatment, but if you're contemplating some other diagnosis, interception is the one that comes to mind, give the enema, and if the child is relieved after the enema, maybe you've made the diagnosis of constipation and you can lay off the ultrasound and everything else you wanted to do. So don't just use it to relieve the patient, think about it as a diagnostic step. Rule number 190. As an emergency physician, as a leader, it is very important to make decisions and move on. Make decisions fast. Don't dwell on those cases. Don't dwell on your patients. Contemplating, especially with the intervention that you're considering is benign, maybe just time consuming, which is unpleasant, yet the patient may need it. Rule number 191. Do not be the emergency physician who intubates the patient, looks like a hero, and leaves the room. Sit with the respiratory therapist or with the intensivist and discuss why you intubated the patient and what is the best method to ventilate the patient on the vent. There are many things to consider, many things to take into account. Thank you again for listening to PEM Rules. Please check out the new Facebook page, which has some information and some educational material that I hope you like. You can write to me back via the Facebook page or the website. Anything you want to learn about, anything you want to hear about, or if you want to come on the show as a guest and talk about a clinical case you had or how you applied the rules in your clinical practice. I'm always happy to hear from you. Thanks again. Hope you like the following outro. This is called Bullet in the Head by Rage Against the Machine from the first album, yes, from the 90s.